So we are live on Facebook now.
Yeah, I'm just sharing it with all the forums.
Okay. So we will be starting in a few seconds now, and welcome to the audience. Those of you who has joined us on this very special webinar.
I'm almost done.
Okay.
Just one more minute and then we are ready to go. We'll start in a minute. We have just 1 minute. We are a little early. So,
Yes.
all right, let's get started.
Okay. Namaskar and welcome to our webinar on COVID health. We have a very special guest lineup for you today. And I'm delighted to invite Professor David Hilmers from Texas. I'm not going to introduce you, Professor Hilmers, that my another other guest, Dr. Cole, will do. But I have looked at your brief, I should say brief bio, and it's as long as my right arm. So I won't go through that all, but you have had a very, very checkered career, and we'll go through it in detail in a bit. But I would like to introduce Dr. Surinder Kaul, who is the other panelist today. Dr. Surinder Kaul, namaskar. You are quite well known in the community, but I'll go through your clinical experience today. So Dr. Cole is the medical director at Sugarland Hospital, Texas. He also served as medical director at Bentop General Hospital, which is the main teaching hospital at Baylor College of Medicine, where Professor Elmers is from as well. Dr. Cole is also on the academic faculty of the Baylor College of Medicine, and he also served as a chair of St. Catherine Hospital in Western Kansas. Now, more importantly, Dr. Cole has been at the forefront of managing COVID patients since the beginning of the pandemic. As we know, India is going through a very difficult time. But last year and beginning of this year, it was rampant in US and Europe as well. And especially in Texas, there were lots of cases of and lots of high mortality as well. So Dr. Cole has managed them all, and he has also developed various protocols and guidelines to manage COVID. So Dr. Cole, very warm welcome to you. And do you want to introduce Professor Hilmers because you worked with him, you know him very well?
Yeah, thank you so much, Dr. Kotwal. I know I call Dr. Hilmers as Dave, but here is a professional webinar, so I will be addressing him as Dr. Hilmers. So it's my honor and it's my proud privilege to introduce to my community as a community outreach educational program, Dr. David Hilmers. I have been associated with Dr. Hilmers for the last 11 years. He is a super physicist. He is a clinician of the clinicians. And he is the physician who has vast experience, multifaceted, have served in various capacities. And I'll be reading his bio shortly. Dr. Hilmers, you will be, our audience today will, they are highly educated and you can feel free to put in certain things that you think that will be in the best interest of common people who are educated lot. And before I go to the bio, our outcome, the goals of today's meeting is that, you know, India is in the middle of the second wave of COVID, and it is causing huge devastation, impacting human lives, threatening human lives. And the NCR region, especially, is very, very chaotic. So, this is an educational program. Basically, I just wanted to make a disclosure statement that this initiative has nothing to do with my institution, Baylor College of Medicine. There are no financial exchanges in conducting these events. This is just with the intent to help people, to educate them, and to see that if some information can help in saving human lives. On that note, I will be reading brief bio of our today's guest, Dr. Hilmers. So David is a professor in Department of Internal Medicine and Pediatrics and in the Center for Space Medicine at Baylor College of Medicine. He has served in a wide range of academic research and clinical pursuits in these departments since joining the faculty in 1999. His clinical pursuits have included international HIV, pediatrics, special needs, aerospace medicine, emergency medicine, tropical medicine, and inpatient internal medicine. His research interests have included infectious diseases such as malaria, hepatitis, HIV, and Ebola, as well as refugee health, micronutrient deficiencies, and childhood malnutrition. He is currently working as an academic hospitalist at Bentop Hospital in Houston, Texas, and has been caring for COVID-19 infected patients since the start of the epidemic. His greatest love is performing international volunteer medical services and disaster relief, and he has delivered care in over 50 countries. He serves as the Chief Medical Officer for Hepatitis B Free, an Australian based NGO dedicated to the prevention and treatment of hepatitis in Asia and Pacific Islands. He is working on NASA sponsored research projects to use artificial intelligence to aid astronauts in dealing with medical emergencies that might arise during exploration missions. He is also currently employed as a research scientist for NASA to devise optimal medical care for astronauts going on mission to the moon and Mars. Prior to attending medical school, he retired as a colonel after spending 20 years in the U.S. Marine Corps as an aviator and electrical engineer and served as a NASA astronaut on 4 space shuttle missions, including the first after the Challenger accident. Oof, Dr. Hilmers, do you have some more things to do in near future? I know I'm pretty sure about that. So thank
So,
you for being with us, Dr. Hilmers. Now, our today's moderator is Dr. Shafalika Ban Kutwa. She is an eminent psychiatrist based in UK, and she has been the moderator for the series of COVID lectures that we had initiated. So back to you, Dr. Kutwa.
so thank you, Dr. Cole, and welcome again, Professor Hilmers. I was listening to your bio and was thinking, is there anything this man hasn't done? So from engineering to aerospace, but we'll focus on your clinical and academic pursuits today, because, like I said, we are in the middle of a major pandemic in India. And if I quote you some figures from yesterday, so we have 188 million people affected, and we've had 208,000 deaths. And every day there's more than 380K positive cases yesterday. And sadly, we have lost more than 3,000 people in a day. So so pretty high figures, even considering the population of India. It's a huge population. And even considering that, the figures are really stark. And so I wanted to start today's discussion with what do you think is going in this kind of contagious disease? What do you think are the challenges which we are going to face or are facing at the moment, and what best practices we should follow, especially with focus on the R naught figures, and what are they looking like at the moment, and what do they actually mean, and how important are R figures in contagious diseases? Thank you, Professor Hilmers.
Well, thank you very much for the kind introduction and for inviting me to come here today. First of all, I'd just like to say how much we really care for the people of India, and here in the United States, we know what you're going through. And we know that you have even greater challenges than perhaps that we have faced here. And I just want to tell everyone that we think about you every day, about what's going on there. You're in our thoughts and prayers. And we just want you to know that you have all our love and support from back here that we can possibly give. And in any way that we can help, I know that our government is trying to free some vaccinations to be able to send them to India. And we hope that we can do more than that, that we can help with the oxygen situation in any way that we can. But just want you to know there that we are thinking about you, that you have all our love and support back here. So we're talking a little bit about what is the virus going to do, and what can we do about it now? It's really a difficult question to know what direction the epidemic is going to take. We know that it's kind of raging out of control each day. We see higher numbers, shocking numbers that are coming out of India. But you can kind of boil down the question into two parts. One is, what is the virus going to do? And what are we as a community or as a nation going to do? So the virus, to a certain extent, is going to do what viruses do. Viruses are going to go out and they're going to try to find individuals that are susceptible. And if there's contact, they're going to try to infect the individual that's susceptible. But we can do certain things to control what the virus is going to do. If we can get the number of infections under control, that means that the virus can't infect others. And the more infections that there are, the more chance there is that the virus is going to mutate. And as it mutates, it causes new variants, and these variants may be harder to treat. They may be more transmissible. So I think in terms of looking at what the virus is going to do and what we're going to do, it's really instructive to look at what we call the reproductive factor. And there are really two flavors of the reproductive factor. The first one is really kind of a characteristic of the virus itself. We call that R naught. And this is what the virus would do. It's kind of its innate infectiousness. And each virus has its own reproductive factor. There are some viruses that are much more contagious than others. And R naught means that what would a virus do, or how many people could it infect with one individual that is infected in a population that is completely susceptible to a virus. And so this might have been the case the first time that maybe the people in Wuhan, or the first time that the virus was seen in India. No one had any immunity, natural immunity or vaccinations at all. So how many people would one infected person infect in addition to themselves? And it's generally thought that depending on the variant of COVID-19, that it's somewhere between 2 and 4. By comparison, probably the most infective, highest R number that any virus has is measles. And that can have an R factor up to about 18. Mumps would be somewhere around 10. The SARS virus, the original SARS virus, maybe about 4. Ebola had an R factor of about 2. Hepatitis C, for example, has about 2. So it's a whole range, and each variant may have its own innate reproductive factor of R0. So that's in a population in which no one has any immunity at all. But probably more importantly is what we call the effective reproductive factor. And the effective reproductive factor takes into account the fact that there are people that are currently infected and they may have some natural immunity. So this changes based on the characteristics of what people are doing to combat the disease and what precautions that people are taking. So we talk about the reproductive factor, and this can change. And the big implication of reproductive factor is once it drops below 1, in other words, there's less than one person or fewer than one persons that are being infected by one infected individual. When it drops below 1, eventually the disease will burn itself out. As long as it's above 1, it means that more than one person is passing the infection along to someone else. So another important number to remember is how many people need to have immunity before the infection will die out. And you can roughly compute that by the formula 1 minus 1 over R. And so the higher the R number, the smaller 1 over R is going to be, and it means that the higher the population that you need to vaccinate. Let's say that the R factor for Ebola, for COVID is 3. So that would 1 minus 1 over 3 would mean that you need roughly 67% of the population that either has natural immunity or vaccination before you'll reach what we call herd immunity. What are the components of the R factor? Basically, there are 3. One is what we call the rate of contact, sometimes denoted by the letter C. And the rate of contact means how many people does an infected person come into contact each day with? Is that person walking around in a crowd, and is he infecting a lot of people, or is he isolated at home? So that's the rate of contact. The second number that goes into the formula is the transmissibility, is what is the probability that there will be an infection if an infected person comes in contact with a susceptible person. And finally, the third factor we sometimes call tau is the infective period. How long does someone that has the disease, how long do they stay infective? Are they infectious for 1 day, or are they infectious for 1 month? So the longer they're infectious, the more individuals that they potentially will infect. So what can we do? What can we do as governments or strategy makers or public health individuals, or as individuals ourselves? What can we do to affect those 3 factors? So we do have some control over them. We can decrease the rate of contact. How do we do that? We can stay at home. We can have lockdowns in the most extreme way of dealing with the disease, or we can restrict commercial and social activities. We can say we're going to close restaurants, or we're going to limit the number of people that can come into a restaurant. We can limit social gatherings to a certain number. And so that's one way that we can decrease the rate of contact. What can we do about the transmissibility? Well, we can wear masks. If everyone wears masks, the disease is not going to be passed from one to another. we can vaccinate, or as people get natural immunity, that's also a form of vaccination in a sense. So we can decrease transmissibility by wearing masks, by vaccinating. And finally, how do we decrease the infectious period, how long someone's infected? We can isolate and we can treat individuals that we find out that are infective. And we do that as soon as possible. So the amount of time that they possibly can infect others is minimal. So how do we do that? We need to have mass testing and contact tracing. Contact tracing, when you have a huge number of infections, becomes very difficult. But identifying who's infectious by having mass testing is extremely important, because then you can get those individuals that are infected, put them somewhere where they're not going to infect other people. So those are the three things that we can do. And by reducing the number of infections, we can also decrease the number of variants, the number of mutants that the virus has, and we can drive that reproductive number down as low as possible, hopefully less than 1. And when we do that, we can get control of this pandemic. So predicting what's going to happen in the next weeks and months really depends a lot on the virus and what we do to control the virus.
Thank you, Professor Hilmers. That's excellent insight. So three key areas to focus on is contacts, transmissibility, and infective period. But the main important thing is isolation, isolating people who are infected, wearing masks. That's the other key thing which you touched on. And I was quite interested when you said about measles with an R rate of 18. That is pretty high. But the good thing is measles is almost, we have eradicated it by vaccination. So we will talk about the vaccination program in a minute. But before that, I would like to bring in Dr. Cole. Dr. Cole, did you want to add something to the points Professor Hilmers has touched on?
No, Dr. Hilmers made a very excellent points. The audience need to understand the nature of this virus, and the contagions are like that. But certain terminologies that, hey, you might have been hearing from the media, hey, the peak is yet to come. So these are the epidemiological projections based on all these scientific data that we are seeing the astronomical rise in the numbers, both in infected patients as well as the mortality. And that is basically, it will go up and then it will plateau. And based on the situations and the infective rate, then it will start dipping down. So that is the process. And thank you, Dr. Hilmers, for explaining it so well. No, I don't have anything much to add.
Yes. So vaccination is our second. It's our way out of the pandemic, as you pointed out, and as we've seen in the West. Vaccination is going to be the key, and we have eradicated lots of diseases by vaccination. So what is your experience of the vaccination program in Texas, where you're based, and how successful has it been in reducing the R number?
So I think that in recent days, as our vaccination rates have gone up, I think the latest figures are that approximately 1/3 of the adults in the United States are fully vaccinated, and somewhere slightly above 50% of the adults have had at least one vaccine. So we've made great progress, and we were vaccinating, I think, as many as nearly 4 million people per day for a while. But recently, we're now getting into a little bit of difficulties with convincing the rest of the country to get vaccinated. There's kind of a core group that is against vaccinations at all, any type of vaccinations, and then there are others that are suspicious of the vaccine. Of course, you've probably heard about some of the conditions that have been associated with some of the vaccines, blood clots, I think with the AstraZeneca and the Johnson & Johnson vaccine, some of them being cerebral blood clots. which sometimes it's very difficult. These are such rare events that you don't know if they're really in the background or is it really due to the vaccine. So that's a problem that many of the regulators have been dealing with. But it really plays in the minds of a lot of individuals that are kind of on the fence. So we're getting close to that magic number of herd immunity. I talked about with how many people you need to vaccinate to get that reproductive number less than 1. But I think we're getting close because we've had so many infections. So there is some natural immunity that we have now. And in recent days, in the recent weeks, I think we've started to drop from that plateau that we were at around 50 to 60,000 infections per day. And I think that we're starting to see a drop. And we're all keeping our fingers crossed and praying that we're on the cusp and we're going down now. The big question is, how long will the vaccinations be good for? No one really knows the answer to that. And also, how long will natural immunity be good for? And then the third question is, what's going to be the effect of variants? Are we going to have more breakthrough infections because the effectiveness of these vaccines, we've talked about the Pfizer and Moderna being 95% effective, but that testing was done when there weren't as many variants as there are now. And so that's another major question that remains to be seen. But there's no doubt whatsoever in my mind that the vaccination program has been effective and will be the key to us getting over the pandemic in the US.
Yes, thank you. And like you said, in India as well, there is a group of population who are saying no to vaccination. So your message to them is no, take the vaccine. It's safe, because that's at the moment looks like that's our only way out, because the option is either mass populations getting the illness with high mortality rates, or getting immunity through vaccine. So that certainly looks like the safest option. So thank you, Professor Hilmer. I'll go to Dr. Cole now, because we will go to a few clinical questions. And like I said earlier, Dr. Cole has been at the forefront of getting some guidelines sorted in the hospital where he works, how to manage the pandemic. So, Dr. Cole, the virus, the infection goes through a mild, moderate, and then a severe stage. And do you want to take us through what are the evidence-based management, not necessarily treatments, because we have discussed treatments in this webinar, but general management strategies of managing the patients as they progress from mild to severe stage of the illness?
Right. So before going on to that, I would like to briefly share with the audience that we do have mild, moderate, severe, and critical spectrum of this COVID-19. So the symptoms of COVID-19 usually are fever, chills, generalized body aches, sore throat. You may have loss of sensation of smell or taste. Some patients may have diarrhea. But there is another spectrum of the people who may be having COVID-19, but they are completely asymptomatic. They don't have any symptoms. And that is the challenge of this COVID-19 to control, how the measures become very difficult. The incubation period as of now is around 14 days, but most of the patients develop symptoms around 4 to 8 days. So that means a patient who is infected and is within the incubation period and is yet to develop symptoms is another challenge of spreading the disease. So 81% of COVID-19 patients belong to the category of mild symptoms to moderate symptoms. And most of the mild symptoms, and I think most of the moderate symptoms also, they need to follow certain things. And what are those? What are the alarming signs? I will just briefly go over them. The mild symptoms may be 1 or 2 days of fever, it will go away. It may have some generalized body aches and it will go away. There are some other patients who have fever for about a week and associated symptoms. But I don't think these are the alarming symptoms. So when patients with these symptoms who have COVID-19, they should monitor their oxygen levels very frequently. And they should preferably monitor their oxygen levels not at rest, but after having a 5 to 6 minute walk and then check it. The alarming sign that when we see that the patient should seek medical attention. I know the currently the situation is very chaotic. They have no many people don't have access to physicians. There are no beds available in the hospital. But I hope this will help you that if your oxygen levels are good, the good means about 97, 98, 95, 96 should be fine. You just do symptomatic and supportive treatment. Take paracetamol for fever, maintain a good lifestyle, take nutrients, vitamins, vitamin C, vitamin D. Zinc has shown in certain studies that these are all immune boosters. It will help your body defense systems. Now, coming on to the patients who are sick, they are around 14 to 15% of the patients are sick who should be in the hospital. And these are the patients when COVID-19 started, there was fear of unknown. We didn't know much about how this virus is behaving, what are the management strategies. When we were trying to develop the protocol, we were reaching out because New York had the initial uh, face the brunt, and we were reaching out to them what has worked, what has not worked, and we were reaching to the physicians in different countries as well what they have been doing. But at that time, it was a very chaotic. We didn't know the guidelines. We didn't know exactly what we were doing. But there were some studies that came out, randomized trials, where there was some good news that steroids has a role in severe and critical patients. So based on that, some progress was made about setting up the guidelines. So currently what we are doing is that hospitalized patients, when they are admitted to the hospital, we do the basic labs like CBC, blood test, be, check their kidney numbers, liver function test, their chest X-ray, EKG, baseline EKG. And then we basically also order inflammatory markers. So there are different inflammatory markers. They do not have any prognostic values, but we do order at baseline, which includes CRP, ferritin, LDH, troponins, procal. So based on the patient criteria, if the patient is sick, we usually, and the oxygen levels are below 94%. I know different hospitals have different guidelines, but I'm talking about my hospital, and I believe that it went up when I was there, we were following almost the same guidelines. So if the oxygen saturation drops, so we evaluate the whole picture of the patient, including the vitals. So if the patient has COVID positive, has established ground glass opacities on the imaging studies, and the oxygen levels are 94% and below, these are the patients we do admit. And we start these patients on low flow oxygen to maintain their oxygen around 92 and above. We do give them steroids at that time because there has been a role of steroids in patients who are on low flow oxygen. It has seemed to change the mortality. Then in selected cases, we try to give them remdesivir at this stage because we have seen that if it is started a little bit earlier, it may have a better role, better outcome. But it is, again, the studies have not shown proven benefits over the mortality. But it has been shown that it may decrease the intensity of the disease, the recovery of the patient. Then we do use convalescent plasma. We have not used it for last 1 month now in the patients, but we have been using convalescent plasma early to help these patients. And then in selected cases who are much more sicker or who have some new infiltrates, who have elevated white counts, where we have suspicion of any bacterial infection, in those cases, we do add antibiotics. But using antibiotics, again, has not shown, um, mm, I mean, say that do we need antibiotics? Do we not need antibiotics? The studies have not shown uh, the superadded bacterial infection role until now. I know that in flu we do have a lot of superadded bacterial infection, but we do use antibiotics in severely patients based on the criteria. Now we have also started using tocilizumab, the IL-6 inhibitors in patients. Again, there are different guidelines. Some follow the guidelines that if the CRP is above 75, if the patient is more sick, we do use them also. The baseline, the hallmark is oxygen therapy. And the oxygen therapy goes somewhere from low flow oxygen to BiPAP to high flow oxygen, and then perhaps depending on the case scenario, we try to tend to delay uh, placing patients on mechanical ventilation, and gradually try to, in incremental way, there are using these tools to keep the oxygen around 90 to about 90%. So good news is, I mean, say you can conclude, we have a 91-year-old female who was admitted because of COVID-19. Everyone was scared, hey, she's not going to do well because of her age. Her performance status was fairly well. And we had several meetings with the family, and we discussed with them. They said that do whatever you can do. But, she did fairly well. She left the hospital walking, talking. And so this is the other side of the spectrum as well. So these are the primary management things that we have been doing. But I would suggest all the audience, if there are any physicians, you know, nothing can nothing can supersede the physician's assessment and judgment. So please talk to your physician, and whatever I am speaking is based on the studies, but nothing can substitute the physician's eye while evaluating the patient. So, Dr. Hilmers, do you want to add something, or do you want to say something different?
Oh, no, that was a really good summary. I would just like to add a little bit of a little bit of comment about um, patients. You probably all get lots of questions about, should I bring my loved one into the hospital? And I know that there's been difficulties with hospital beds, also with oxygen, et cetera. And so it's a very, very difficult question to answer. But I think that everyone should kind of be able to assess their own risk for a severe infection or a critical infection. And you can generally tell someone that is maybe under 50 years old, that is in good health, doesn't have other medical conditions, that unless they are extremely short of breath, that they're probably going to do well at home. But anytime you add some of the major risk factors, age over 65 by itself is a risk factor, obese patients, patients with diabetes, patients with high blood pressure, with heart problems, patients that are immunocompromised anyway. Are they on suppressives? Do they have some sort of autoimmune disease? Anyone that does someone that has cancer, those patients, I think that you need to be very, very cautious, even if they have fairly mild symptoms, that they are really at high risk for developing severe infections. And so I think that that's an important part of trying to advise patients, and generally just telling people, to be able to reassure them if they really don't have any high risk factors, that they're probably safe remaining at home, and their own immune system will probably take care of the virus. But if they have any of these risk factors, that it's better to assess those patients in the hospital. I would also kind of like to just uh, affirm some of the things that Dr. Call said. I just did a rough run through of a lot of these kind of high tech um, therapies that are investigational. And as far as the NIH, our National Institutes of Health, and the Infectious Disease Society recommendations, that most of these things, such as convalescent plasma, all the different monoclonal antibodies that are out there. One of the best known is Regeneron, because that I think President Trump was one of the first people to receive that. IVIG, those are really haven't, the evidence for them is really pretty shaky right now. And the NIH actually recommends that none of those things be done in the hospital outside of clinical trials. So you can feel pretty confident that with just supportive care and with oxygen and using those things that we do know work. We know that dexamethasone works. The recovery trial was pretty impressive. That was the trial that was done in England back last year. And it shows that you can prevent by treating 8 ventilated patients, you can prevent 1 death with using the steroid protocol. In patients that are on supplemental oxygen, you can prevent 1 death by treating 25 patients. Dexamethasone is very cheap, and so it's a very, very effective treatment. So anyone that has an oxygen requirement that's in the hospital should definitely be placed on that. Remdesivir, as Dr. Call pointed out, it has some marginal effects. It does reduce the recovery period. And so it does help, but is it a magic bullet? No. So really the keystones of medical care are supportive, oxygen, and steroids. Personal little preferences that I tend to like to use incentive spirometry in patients. One thing is that it does help expand the lungs, but also it kind of gets the patient involved in their own treatment. It's something that they can do, and they can kind of monitor their own capacity, and it makes them feel like, rather than just sitting in bed, that they're actually doing something. I tend to use some of the nutritional supplements that Dr. Call is saying. Whether they help or not, it's still up in the air, but they certainly don't hurt. And if a patient is deficient in vitamin D or in zinc, I think it definitely is promising that you could do that. But I just wanted to stress the things that Dr. Call mentioned, that those are really the keystones of our therapy.
Yes.
Thank you, Dr. Hilmers. I would like to add one more thing here. We do our patients who are on supplemental oxygen, whether they are on low flow or high flow, we do prone them. Proning has shown better outcomes in oxygenation of the patient. The oxygen requirements definitely improves with proning, but it's a difficult practice. Our nurses are trained to help patients prone. Even ventilated patients who are on mechanical ventilation, they are also having periods of proning. That has also been there as a part of protocol.
Yes, that's excellent advice, Professor Hilmers. I was particularly, you touched on patients being part of their own treatment, because the pandemic is so widespread. A lot of burden is falling on families and carers. And so there needs to be some kind of a mass education program to get the patient and the family involved in the treatment, rather than relying on hospitals and medical staff, which are in short supply at the moment. So that's a good point about using spirometers and things you can do at home. Obviously, if things worsen, then hospital is the next step. So, and like you said, plasma doesn't have much evidence. It's used quite a lot in India. And the only other thing was, in India, we have noticed, you might have read, a lot of younger population is being affected, people in their 40s and 50s. We didn't see that in Europe. Like you said, in US, if you are young and reasonably fit and no comorbidities, chances are very high that you will get better. And we saw that in UK as well. For some reason, whether it's a mutant virus or what has happened, we have seen a lot of younger people with no comorbidities being affected. So that probably needs to be studied at some point. What is the reason for that in India? Professor Hilmaz, I was in your bio. You're also a pediatrician. All the things you do, you look after children as well. So the signs and symptoms of COVID are quite different in children sometimes. Do you have any experience, for instance, of multi-system inflammation in children, and what are the kind of treatments you are using to manage that?
So that's a great question. It's important to remember that children and adolescents are just as susceptible to infection as with COVID as are adults, but for reasons that aren't quite fully understood, symptomatic primary infection is significantly lower, and rarely do there are we read about cases of very, very young people, adolescents, or children that have that die from COVID, but it's very rare that happens. And so, for the most part, we don't worry about kids too much. But there is one important thing that I would like to talk about, and this is, as you mentioned, this problem called multi-system inflammatory syndrome in children, or MISC. And we've also found that this same sort of syndrome has been reported as a rare complication in usually young adults. I think the oldest one that I've seen is maybe in the 40s. But this looks to be a high inflammation state that comes about as a result of even an asymptomatic infection with COVID-19, and it's in many. It has an appearance that's similar to Kawasaki's disease in young kids, or toxic shock syndrome, or one of these hyperinflammatory states such as the microphage activating syndrome, or hemophagocytic histiocytosis. And so it does look like some of these very highly inflammatory states. And what's really unusual about this is that generally the children that get this, and we've had well over 100 cases at our hospital at Texas Children's Hospital in Houston, well over 100 cases of this, where kids come in with several days of very high fevers. The criteria that the CDC has had for this infection is that for MISC, that the children are less than 21 degrees, less than 21 years of age, that they've had fever for several days without explanation. There's increased inflammatory markers or signs of inflammation, and oftentimes they'll have 2 or more organ systems involved. That could be cardiac, renal, respiratory, gastrointestinal, that there's some evidence of either a previous exposure or infection, and there's no alternative diagnosis. So the important part of this is recognizing it. And so generally, I tell people that are in the hospital and have recovered from COVID, as they go home, I tell all my patients that if you have children at home, they have unexplained fever for 3 or more days, but they don't have the typical respiratory symptoms of COVID, that they should seek medical care, because the medical care for this is a little bit different than how you would treat COVID, because they usually don't have respiratory symptoms. They should be tested. And then if they're showing these high fevers, these high inflammatory markers, what they need to be treated with steroids. And actually the most effective treatment is IL-1 inhibitors. Anakinra is the drug that's been used very successfully here. So the point that I'm trying to make is that if you see a child that's been exposed to COVID-19, either maybe has had a asymptomatic infection or a mild infection, and 4 to 6 weeks after that exposure, maybe someone in the household has had COVID. If you see a child with multiple days of unexplained fever, they need to go to the hospital, because this is something that needs a special sort of treatment. It could be something like Kawasaki's disease, but what we're seeing now is a lot more of these cases of multi-inflammatory syndrome in children. Now, I was on a panel that came up with guidelines that looked at what should we look for after vaccinations. Now, right now, there aren't too many children that are getting vaccinated because the Pfizer vaccine requires that you be 16 or above. But we're looking at vaccinating children now, and there are clinical trials that are looking at dropping the age for the Pfizer vaccine down to 12. And so the question becomes, if you're exposed due to a vaccination and you develop this inflammatory syndrome, what are the signs that you should look for? There have already been some case reports in adults of people that we suspect may have had this inflammatory syndrome after vaccination. So it's something to be on the lookout for.
Yes, thank you, Professor Ilmaz. That's very good advice. Now, US and hopefully Europe as well, we are coming out at the other end, fingers crossed. And long COVID is something that has come up now. Have you, you and then Dr. Cole, have you had any experience of seeing patients with long-term effects who have recovered but still have some niggling symptoms? Have you had any experience of dealing with these patients?
Well, I'll take a little crack at that. I think that this is really something that needs to be considered in the long term, because some studies have shown that up to 30% of all patients with COVID will have lingering consequences of the disease, and that can last. We're about a year into this epidemic, and we've seen some of the people that had early cases of COVID back in March of last year, and still continue to have some lingering side effects. And some of those side effects can be neurologic. That's one of the most common. People describe kind of having a brain fog. It's just like, I can't think clearly. A lot of the signs of chronic fatigue syndrome that we see, just tiredness, neuropathies, just having constant pain. And it can attack pretty much any of the systems that we see it in the acute phase of the infection. So we define this phenomenon called long COVID as effects that last more than 2 to 3 months after the acute infection is over. And this is an important, very important consideration for just the whole public health network. Strategies to look at how are we going to deal with this great mass of patients that continue to have symptoms far beyond the initial acute infection. So I think that this is one of the consequences that right now we're in the midst of the pandemic, and we're just scrambling, particularly in India, scrambling just to treat and prevent deaths. But we have to remember that the consequences of these acute infections are going to be with us for years to come. Dr. Call, do you have any comments on
Yes,
that?
yeah, you're right. I've seen patients who have been on mechanical ventilation are higher risk of developing long COVID. So because patients with COVID pneumonia with acute respiratory failure, they're on prolonged ventilation. I've seen that the patient is on ventilator for 1 month, 3 weeks. So I think that definitely has an impact on various aspects that Dr. Hilmers already mentioned. But we are seeing some patients as a follow-up. they are showing some incremental improvement, but there is an improvement. But yes, it takes around 8 weeks, 12 weeks. So it's a slow process of improvement. But these are the patients who need some respiratory rehab. Many patients do require that, and there are certain exercises they need to follow. But overall, this was on the lung. But then, as chronic fatigue syndrome is coming up, definitely, and neuropathies and all that stuff, but studies are still evolving about the long-term effect of COVID after their acute recovery.
Yes, thank you.
It seems to be that there are risk factors, as you mentioned, that being the more severe your infection, if you were on mechanical ventilation, that it takes obviously it takes longer to recover. That's almost a separate issue. When I was working in the ICU, I would see patients that you could hardly recognize their lungs after an infection. I mean, it didn't even look like lung tissue anymore. Their lungs were just more like Swiss cheese, and just some horrible effects. And so those patients are going to need they may need to be on long-term mechanical ventilation. They may need, a lot of the patients got tracheostomies, and they were sent to long-term care facilities where they were on long-term ventilation, but the recovery is very, very slow for them. So the more severe disease, the longer obviously it's going to take. There's the ICU syndrome that many patients get, just ICU muscle weakness, myopathies, et cetera. There are also the people that develop long COVID. Those that are older seem to develop it more often. People that have underlying lung disease like asthma or COPD, if they're obese, they're at more risk. And for some reason, the epidemiology shows that while women are less likely to develop severe acute COVID, they're more likely to develop long COVID than men. We're not quite sure about that. So there's a lot to be learned about it. And, as we're the longer that this epidemic has been with us, the more, the smarter we get about this as we collect more data. But this is, I think, an important consideration for policymakers to realize that the effects of COVID are not going to end when the acute pandemic ends. When we get past that, it's going to be with us for a while.
Yes. So we have to have a public health strategy. At the moment we are looking at acute management of COVID, but long term, as you said, we need to have a long term public health strategy. I just quickly wanted to, we are nearly coming to the end of the webinar. I just quickly wanted to ask you about your experience during Ebola, and that must have been very difficult, especially it was in the sub-Saharan Western African region. Did you get personally involved in management of this? What was your role, and do you have any insights you would like to share? Because that must have been pretty horrendous with a 25% mortality rate, and how did you overcome the challenges, and if there's any learning from these kind of pandemics we've had in the past?
Yeah, so I worked as I was the chief medical officer in one of the Ebola camps that were set up in the U.S. by the U.S. in Liberia in 2014 and 2015. And there are a lot of differences between Ebola. First of all, Ebola was it was spread by contact rather than airborne. So the personal protective gear that we had to wear was much greater. It took us probably about 25 minutes to get out of our equipment, and 10 or 15 minutes to get in. It was much more extensive. But I think that the big lesson that I learned with Ebola was just preparation, and the effects of really what turned the Ebola crisis around was not vaccination, even though we weren't vaccinated when I was there. The vaccines hadn't been developed. But really what took care of Ebola and really helped finish off the epidemic was personal habits. And so when public education, when we were able to tell people that you need to wash your hands, that you we need to isolate anyone that's sick at home that has symptoms of Ebola. You need to immediately tell people in the public health community that you have a possible Ebola patient there. You need to get them isolated. You need not to do things like doing during funerals, washing the body of Ebola patients. That's how a lot of people were infected. So, the advice is a little bit different, but what's really, really important is personal habits, doing those things that prevent the virus from spreading. And those lessons can be taken to the COVID experience as well. Isolation, wearing masks, wearing good hand hygiene, isolating patients that are known COVID carriers. All those lessons that we learned in West Africa that eventually caused the Ebola epidemic to die out are what is key. Those public health measures are really key. Once we got the vaccinations, we had a little bit different strategy for Ebola vaccinations. We didn't have enough to vaccinate the entire population, but the importance of vaccinations in reducing the effects of an outbreak. We saw that in the Congo with recent outbreaks of Ebola. By using vaccinations effectively, it can go a long ways towards eliminating the disease. And so, I just kind of like to go back to those measures that we talked about when we discussed the reproductive factor, that we need to isolate, we need to vaccinate, we need to wear masks, and we need to identify those patients who are positive. And by doing those things, we can defeat this virus.
Yes, thank you, Professor Hilmers. And the good thing is it's mostly eradicated now, Ebola, I think, in most parts of Africa. So if we can conquer that,
Yeah.
we should be able to.
Well, but it's out there, and it can always pop up again. It's got its reservoir, and I suspect that COVID is going to be the same. That even after we vaccinate, the virus is going to be out there, and we don't really know if we're going to need booster shots or not. Is it going to be like a yearly flu shot, or is it something that our immunity will last a long time? But we're not going to vaccinate the entire population, and so there's going to probably be outbreaks now and then. But hopefully, we'll make this manageable. We'll be smarter about treating it. We'll convince more and more people to get vaccinated, and hopefully we'll cut down on the number of new variants that are out there that can escape the vaccinations that we have.
Thank you, Professor Hilmers. That was a very insight. I learned a lot. Although we've been having these webinars for 7 days now, but every day we learn something new. And thank you for your wonderful, wonderful insights. I would like to go back to Dr. Cole to finally wrap up this session. But on behalf of the audience and on behalf of me, thank you, Professor Hilmers. It was great having you today.
Well, thank you, and our love and support is with the people of India.
Thanks. So there are certain things that we are reiterating every now and then, and every session that Dr. Hilmers also reiterated about the importance that what can I do at my level, what I can do to protect my family, what families can do protect the community. So this becomes the whole thing, and if that information percolates, that's how the whole nation is there. A couple of things that I actually got the questions was that we always say that mild to moderate, don't worry about oxygen anything between 90, about 92% is okay. But there is a small window, because if oxygen is dropping acutely from 98, 97, 95, 96, under these situations, first is try to keep your supplemental oxygen handy, because it's very difficult to predict which one will go very down the hill and have rapid deterioration. So keep it ready because oxygen is very important. Second thing is that when a patient with comorbidities are showing the earliest signs of COVID-19, be very watchful. And one of the alarming signs, definitely don't ignore shortness of breath. If there's a persistent shortness of breath, at the earliest time, seek medical attention. Vaccination, we see all the time the questions that I have been vaccinated. Now, do I need to take precautions about social distancing and masking? Yes, because your vaccination is not, uh, you can still have COVID. The only studies that is still evolving is that you may not get severe COVID or you may not get that bad COVID, but your chances of getting COVID are still there. Then another questions, common questions that comes is that, hey, if I have COVID, uh, I'm immune. So do I need to take precautions? Yes, you need to take precautions. If you get COVID-19, we don't know how long the immunity is lasting, whether it is for 3 months, 6 months, we don't know. So take absolute precautions as if you are not vaccinated. So vaccinated is not a license that you will not get COVID again. With that, I think this was sort of informative session with Dr. Hilmers, and Dr. Hilmers shared his experience. We feel very honored, Dr. Hilmers, for receiving all these important tips at this time of pandemic. And we wish you all the best. You know, it is really a very bad situation in India. Uh, Take care of yourself, take care of your loved ones. There are certain things that you can take control and prevent. As a note that, I have been in the ICU settings seeing patients of COVID-19. I have been seeing patients on the floor. Touch wood, I don't know what will happen next, but as of now I have not got COVID, even though many physicians, many nursing, many medical teams have got COVID. But my what I'm trying to say that if you are vigilant, if you are doing something right, uh, you will not, you may escape getting COVID. But I know there is some element of luck also there. But do practice safe practices. That works. That works. So on that note, any last comments from you, Dr. Hilmers, before we close this session?
No, I think that you very eloquently summarized what we had talked about, and just to remember that, that the virus is going to do what the virus is going to do. So what we have control of is what we can do, and just be safe. And this, the one thing that will happen is that this will pass, and so just have hope. Times seem pretty dark right now, but I don't know how many waves we've been through in the U.S. Maybe 4 waves, different waves of COVID, and it will pass. And as vaccinations increase, I think that hopefully we'll get past this permanently, and there will be no more waves after that. We may still have infections going around, but at least there won't be the enormous size of those numbers that we're talking about now. So God bless and be safe, and take care of yourselves. And thank you so much for what you're doing.
Thank you, Dr. Hilmers. So this was our last session of our COVID health series. So we wish you all good health, stay protected, so take care of yourself, and all the best. Thank you, Dr. Kutwal, for being a wonderful moderator, and you have been doing it for the whole week. We really appreciate your hard work. With that, we will bring it closer to this. Thank you so much.